Concepts in refractive surgery.
Assalamu alaikum. In this video, I am going to explain the importance of and how to perform cyclotorsion compensation before PRK, LASIK, and SMILE refractive surgery. I hope you will enjoy.
Cyclotorsion compensation is essential in the case of more than 1.5 diopters of astigmatic correction, such as in this case. That's because laser profile should exactly match the measured ocular astigmatism, which is measured in the sitting position. When we change our position from sitting to supine, our eyes rotate. That is known as cyclotorsion. There are individual differences in the degree and direction of cyclotorsion. If cyclotorsion is not compensated for, a mismatch in the axis between laser profile and subjective astigmatism occurs. That is known as the angle of error. This error leads to residual astigmatism with a new magnitude and new axis, and in many cases, the astigmatism is irregular. Studies have shown that the magnitude of the residual astigmatism is proportional to the angle of error and to the magnitude of the pre-op astigmatism. The larger the magnitude of the pre-op astigmatism, the larger the magnitude of the post-op residual astigmatism, and the larger the angle of error, the larger the magnitude of the post-op residual astigmatism. For example, if the angle of error is 10 degrees, a new post-op astigmatism is induced that equals a third of the pre-op astigmatism, but on a new axis. If the pre-op astigmatism was 4.5 diopters, the resultant astigmatism is 1.5 diopters, but on a new different axis. To avoid this error, cyclotorsion should be compensated for. In some machines, this is automatically done by the machine by iris and limbal registration technologies, while in others, that should be performed manually. There are two methods to do that manually: the slit lamp manual method and the instrumental method. In the slit lamp method, you rotate the beam to be horizontal at 180 position. The head of the patient should be positioned correctly. You target the center of the pupil of an eye, here it is the left eye, and then you move the beam to the other eye. If the beam transverses the pupil center of the other eye, the head is in the right position. Otherwise, you need to adjust the patient's head. You may need to repeat the steps until you are sure of head alignment. After being sure of the position, you put the marks at the limbus at 3 and 9 o'clock in both eyes. This is a short video showing the slit lamp method. In the instrumental method, there are two types of devices, the weight and the bubble devices, but the principle is the same. The head should be adjusted to avoid any tilt, and the device is applied. This is how to apply the bubble device. And this video shows the application of the weight method. Excimer machines use different techniques to show the zero line, which is 0, 180. Under the excimer machine, after being sure that the head is not tilted, the zero line, or whatever similar, is projected onto the cornea and should match the marks on the limbus. If there is a mismatch, the head position should be adjusted until the proper matching is achieved. If we are planning for smile, the marking should be on the cornea rather than the limbus. We must use special marks that do not block the femtosecond laser beam. The marking can be done as described before, either on the slit lamp or by using the devices. And then the best way is to follow the method described by Dr. Shri Ganesh. After applying the suction, you just need to rotate the cone gently until the 0-180 line in the cone matches the marks. In this way, the smile profile matches the meridian of the subjective astigmatism and is applied where it should be. Thank you very much.